Welcome back, everyone. I do hope that you enjoyed that short break, got some refreshment. Let's say thanks to Healthy Futures Limited for providing us with those refreshments. Now, just a reminder to please be mindful as presentations are ongoing. We do know that you do need to visit out into the hall or step out to make a phone call, but do be mindful that presentations are ongoing. So we do ask you to keep the noise to a minimum. Now, let's get back to the program as we close the main doors. We will invite Dr. Dhruva Krishnan. He is the Medical Director, Senior Consultant, and Head of the Anaesthesiology and Intensive Care Department at Health City, Cayman Islands. He will be presenting on the topic of quality and clinical outcomes in healthcare. Ladies and gentlemen, join me in welcoming Dr. Dhruva.
Morning, everybody. I stand between your lunch, and healthcare outcomes and quality is what is given to me. I'll try to do justice with 40-45 minutes of talk. Data outcomes is not something which everybody likes, particularly pre-lunch. So this is what I would try to cover: the quality outcomes, key performance indicators, and lastly, I'll cover about the business intelligence and the data analytics. Can we just have a show of hands? How many clinicians, doctors in the room, please? How many nurses, paramedics in the room? Okay, thank you. So despite years of research and attention, there is not a single definition which is agreeable when we talk about quality. It depends on whom you ask, what is their goals, what is their priorities, whether it's the patients, the insurers, the payers, the regulators, the patients' relatives, the clinicians, the healthcare organization. Everybody got a different definition. One of the widely accepted classification of quality is by the Institute of Medicine from 1999, where quality consists of a degree to which health services for individuals and populations increase the likelihood of desired clinical outcomes or health outcomes, are consistent with current professional knowledge, that is the evidence-based guidelines or professional practitioner skills, meet the expectations of healthcare users, that is the marketplace. The same Institute of Medicine, a couple of years later, came out with high-quality healthcare, and they quoted 6 domains of healthcare. So the high quality of healthcare consists of safe, effective, efficient, equitable, timely, and patient-centered care. If you ask JCI, they came out with 10 attributes for defining high-quality healthcare. So the definitions are different depending on which organization you speak to. But in all definitions, patient safety plays a very important role in quality of healthcare. WHO added an integrated piece where when you have patients with multiple comorbid conditions, the discussions between the team or multidisciplinary team approach where there is a coordinated care between consultants and doctors so that the care given to the patient, apart from the 6 domains which we discussed, is also integrated to the patient. To Err is Human is one of the leading papers which discussed about the quality of healthcare or how unsafe healthcare was. Some of the high patient profile errors which happened in the 90s in the United States this led to the catalyst for this paper to come out. And in this paper, they extrapolated data from 3 to 4 hospitals. And they published around 100,000 Americans die each year as a result of medical errors. And this was grossly underestimated because it was an extrapolation. The Institute of Medicine, their committee came out with another paper called Quality of Healthcare in America, Crossing the Quality Chasm. That is where the catalyst for looking at the quality in healthcare, looking at the patient results came up. Around the same year, around the same time in the UK, there was a white paper called the New NHS, which was published in 1997. One of the major take-home points from that paper was to bring out a major improvement in the quality of clinical care delivered to patients in NHS. Few years later, the Chief Medical Officer of NHS in 2000 came out with a report of an expert group of learning And that paper was titled as An Organization with a Memory. Some of the take-home points were around 400 people died or had adverse events because of medical devices. Nearly 10,000 people had medication errors in NHS across UK, and around 15% of patients who got admitted to hospitals in UK NHS had avoidable healthcare-related infections, which would have costed the NHS around £1 billion. This was 2 decades ago. So the writing was on the wall that hospitals weren't safe, and quality of healthcare was important. And the CMS and National Quality Forum published their first 20 clinical outcomes in 2005, and they began the Hospital Compare program. Since then, the number of quality measures have increased. They increased it to 40 outcomes or process measures in 2014. 30-day mortality were added in 2008. 30-day readmissions were added in 2009. Currently, the CMS Hospital Compare program in the United States has got more than 150 quality measures and process measures that are measured and reported. The Joint Commission took a leadership position when it came to patient safety goals, and they came out with the international patient safety goals that a lot of hospitals around the world follow. This was developed in 2006. It has gone through 3 revisions, or what we follow now is the 3rd iteration, 2017 to 2023 versions. They came out with 6 international patient safety goals where every touch point of the patient in the different hospital settings or across the patient's journey through the hospital can lead to error. And the compliance to these international patient safety goals is primarily important to make sure the errors are prevented, errors can be reduced totally. The first goal is International Patient Safety Goal 1, where we identify the patient correctly. The first name, the last name of a patient, and the date of birth in an outpatient setting. The first name, the last name, along with the medical record number, is used across the world to identify the patient correctly so that the right patient gets the intended care. So wrong patient doesn't get that. That is what we do. And the International Patient Safety Goal 1 audits are done around the hospital to make sure everybody is compliant with what we say is the policy to identify. On this small island of 60, 70,000 people, we've had a very interesting thing. There are 2 patients with the same first name, last name, and date of birth. We had a lot of struggle when we went through. We followed IPSG 1. The first name, the last name of the patient were correct. The date of birth also, both the patients share the same date of birth. And when we showed this as one of our issue, what we had during the previous JCA, some of the JCA surveys had not seen anything like this in 130 countries with more than 2,000 hospital surveys. So it was a struggle for us to go back to the insurance, go back to the patient, and then rectify the problem. We ourselves were cracking our brain. So anyway, this is what we learned. In International Patient Safety Goal 2 is about effective communication. If you trace the journey of a patient through a hospital till the patient gets discharged, there's multiple handovers. Multiple places the handover takes place, the shift of duties takes place. So every handover is a potential for error. You may not have a complete handover, you will have incomplete handovers. So there are studies which have shown that the delay in treatment, the medication errors, a lot of complications to a patient are because of incomplete or ineffective handovers. So they've come up with standard templates for handover. The SBAR form is one of them, where we tell the care providers what to hand over so that the information is completely transmitted and there is no loss of information when you have handovers. IPSG 3 has got to do with everything about medication errors. The number of medication errors are phenomenal in a hospital. So a lot of these errors may not reach the patient, but they all have to be prevented. The ones which reach the patient can cause significant complications, either increased length of stay, adverse reaction, and so on. So we have policies to make sure the medication errors don't happen, and even if they do happen, it doesn't reach the patient. It could be a high alert medication, it could be concentrated electrolytes, antibiotics, simple things like checking allergy before prescribing a drug. If we omit the simple step, there are chances that you would potentially prescribe a patient an allergic medicine which he was allergic to. The same way, the Institute of Safe Medication Practice have got 4 or 5 group of drugs which can cause predominant complications: heparin, concentrated electrolytes, potassium chloride. The third is the hypotonic saline, narcotics and opioids is one of them. So we have policies to make sure all of this don't reach the patient or any errors don't reach the patient. IPSG-4 is all about ensuring safe surgery for the patient. IPSG-5 is to prevent healthcare-associated infection. Simple things like hand hygiene can cause infection to the patient. IPSG-6 is to make sure no patient has injury during a fall or no patient has a fall in a hospital. WHO, with a lot of inputs from UK clinicians in the year 2008, June 2008, came up with the WHO surgical checklist, and it was mandatorily implemented across all NHS by January of 2009. It has got multiple components: sign-in, time-out, and sign-out. Sign-in is basically done when the patient is awake. You speak to the patient, ask their first name, last name, verify that the surgical site is marked, and you have the correct patient having the correct procedure at the correct time. So, timeout is done just after induction of anesthesia before surgery is done to make sure the blood, if there's any surgical concerns, the surgical team, the anesthesiology team, and the nursing team are on the same page. And sign out is before the patient is wheeled out of the operating room to make sure if there's any concerns post-operatively, whether it's a bleeding, drain care, antibiotic, all of that. Whenever we followed the WHO surgical checklist, 100%, the chances of you having a wrong patient surgery or complication during surgery are far, far lesser. So it is mandatory for us to have a checklist before a surgery. WHO defines outcome measures as the change in the health of an individual or group of people or population that is attributable to an intervention or series of interventions. WHO again defines patient safety as all these processes and procedures where consistently and sustainably lower the risks for the patient. It reduces the occurrence of avoidable harm, makes error less likely, and it reduces its impact even when it does occur. Why do you have to measure the outcome? Around 500,000 annual deaths because of hospital errors as reported by Leapfrog organization in US. WHO has reported that in high-income countries, 1 in every 10 patients is harmed while receiving the care in a hospital. 7 out of every 100 patients can expect to have a healthcare-associated infection. This is in high-income group. When you go to low-income group, the risks are much, much higher. And around $45 billion is spent on avoidable complications and readmissions. You're looking at $50,000 to $20,000 for each readmission. In the year 2018, 3.8 million readmissions were reported in the United States. This was 5 years ago, and the number of readmissions are increasing. It's around 12 to 14% around the world, the readmission rates. Approximately 2 million healthcare-associated infections occur annually in the US, and the estimated is around 90,000 deaths, causing around 4.5 billion. So you have to look at all the outcomes. This is the never-ever events published in NHS annually. You are looking at least 400 to 500 patients having a never-ever event even today. And this is the NHS report from wrong side surgery, wrong blood transfusion, to retained foreign body, to medication errors. All of this are reported in their website. It is for everybody to see. So these could be totally prevented if we look at quality and outcomes of the patient. So we looked at the triple aim of healthcare, where the goal of measuring, reporting, and comparing healthcare outcomes to achieve the improved patient experience of care, improve the health of the populations, and to reduce the per capita cost of healthcare. Subsequently, a fourth arm or a fourth aim was added, where the clinicians and staff burnout also has to be reduced. So that is the fourth or quadruple aim of healthcare. The outcome measures reveal areas in which interventions could improve care. It tells the team whether the changes they are making actually lead to improvement. Not all changes that we make necessarily lead to improvement. We'll have to learn and then change our approach. It helps us identify variations in care. More such variations in the standard of care, you are bound to have complications. Compare the effectiveness of various treatments. Florence Nightingale came out with a simple 3-point health-related outcome measure. She based it on the 1845 Lunacy Act, where the patient's symptoms were relieved, patient symptoms were unrelieved, or patient was dead. So these are some of the key performance indicators published by different hospitals across the globe. It depends on the quality of care they are giving on the departments they have, from infection control data, blood transfusion data, readmissions, and then anesthesia-related complications. We also looked at the process measures. Outcomes will tell you the end point, but process measures are equally important. And process measures illustrate how systems can improve healthcare outcomes by improving the processes. The number of processes also have increased significantly. Every time we've had an error or a complications, we are learning from it and we are adding another step or another process to make sure that error or complication doesn't get repeated. Simple things like assessing the skin. When a patient gets admitted to the hospital, the clinician and the nurses can do a simple skin assessment tool. Based on that scoring, you will know whether the patient is high risk for bed sore or not. If the patient is a high risk for bed sore, mitigation steps can be taken, and you can take all steps to prevent a bed sore from developing. Now, bed sore development is an outcome measure, but skin assessment that we do on admission, if it's done in a timely manner, and you know that this patient is going to be high risk, you can take steps to prevent bed sores from measuring. So that is how the process measure is important. And we do audits, or hospitals do audits, to make sure the skin assessment is done for all the patients on admission. These are some other process measures which can be conducted, like medicines reconciliation. If the medicine reconciliation is done before giving, the chance of medication errors are high. Same with the medicine reconciliation when a heart failure patient gets discharged. He has to get the right beta blocker or right diuretic medicine. If those medicines aren't part of his discharge medication, you will have a higher rate of readmission for heart failure patients. The fall risk assessment, a lot of elderly patients who have gait disturbances, who are on a lot of medicines which can alert their consciousness or make changes in the consciousness level, painkillers, opioids, benzodiazepines. If their fall risk assessment isn't done on admission to hospital, they are a higher risk for fall. They will have an injury because of fall. Same way, any patient who gets admitted for a surgery, if we don't assess their risk of having a thrombus embolism or thromboembolism, like obesity, previous history of DVT, you will have a higher risk of DVT after the surgery. Aspirin on arrival, a simple aspirin, one small dose on arrival for acute coronary syndrome has shown that their major adverse cardiac events are lesser. So that is why we see the aspirin on arrival for all emergency patients in triage with chest pain. Medication error, there are multiple processes which can be measured for preventing the medication errors. IPSG1, like I told you, the first name, the last name, and the medical record number or the date of birth. The sick writes of medicines, the right patient, right time, right dose, right duration. All that can be made sure it is done. We have a prescription policy for all the high alert medicine, how to do, what are the abbreviations which can be used, which abbreviations cannot be used. The appropriateness review on medication reconciliation is done with the pharmacist on admission and at regular intervals frequently. We have a 2% check policy for all the high alert medicines. Whenever 2% don't check it, your chances of error are higher. There is a policy for look-alike and sound-alike drugs. Some of the drugs like fefcorlin and scolin might sound the same. So that's where we want the nurse or whoever is the treating team to tell back that what they have heard and make sure it is right. And whenever there is a variations in all the steps which happens in series, you are bound to have a complication which will reach the patient. So whenever there is a variation in the inherent standard of care that is delivered to the patient, more such variations, your complication rates are bound to be higher. This is like the Jackson-Rees, or this is the Swiss cheese model by James Rees, where we layer multiple defensive protocols and checklists to make sure error does not reach the patient. Whenever multiple protocols, checklists are not followed, there are chances that the error happens and this error will reach a patient. So all these barriers are the checklist, policies, procedures that every hospital or we lay down so that the chances that individual healthcare worker can make an error are lesser. So the system is made so robust with protocols and checklists that an individual should not be able to make an error. But even if it does make an error, if this happens in a series, that is when all the barriers are violated and the errors will reach a patient. Sometimes the error is picked up at the last step, just before it reaches the patient. We call it the near miss. So the healthcare industry should embrace an attitude where errors are picked up and you don't blame and punish the individual, and all these near misses are used as an opportunity for learning. And we create value from adversity, and then we make more protocols and checklists such that this should not happen the next time. So same thing with healthcare-associated infections, simple things like hand hygiene. If healthcare workers don't wash their hands before touching the patient or before doing a procedure, you are bound to have an infection in the hospital. So we do audits to make sure everybody are 100% compliant with hand hygiene. There is no point giving higher antibiotics when simple hand hygiene compliance rates are very, very low in a unit. Same way we have policies for environmental cleanliness, environmental hygiene, how to sterilize things. All of them have their set protocol, and everybody will have to be compliant with what they say they are doing, which is as per their manual. More variations in all these protocols and checklists, you are bound to have healthcare-associated infection, which is going to increase the length of stay for the patient, which is going to lead to more complications for the patient. So now benchmarking is also important apart from measuring the outcomes, where we compare the performance of an organization or clinicians to others to make sure where we stand, whether we're progressing in healthcare industry or we are deteriorating in our quality and standards. We could have an internal benchmarking where if we have two departments or two consultants, they are benchmark against each other's performance. We can also have an external where a department or a physician from one hospital is compared to another physician or a hospital or other department from another hospital. The comparison metrics are most accurate if you have a proper comparison group, also called the peer group, which is very difficult to get. The critical component of successful quality and performance improvement comes from benchmarking. You will know your year-on-year performance when it comes to infection, when it comes to mortality, whether we're doing well, not doing well. These are some of the characteristics for an ideal peer group, which may be difficult to get. So unless you get a good ideal peer group for comparison, we usually use a trend. So the outcome measures can have bias. One of the things which I mentioned before is because the hospital level attributes where the patient volume, teaching status, whether they have all specialties or it's a single specialty hospital, all this can have an effect. The risk adjustment is what we define because of the patient case mix. An 85-year-old frail patient having a surgery cannot be compared to a 35 or 45-year-old healthy male having a surgery. So that case mix has to be adjusted. That is what we do with risk adjustment. The reliability adjustment is because of the denominator. The lower the number of patients we compare, how do we prove that something has happened by choice? Some of the rare complications, how do we prove that it has happened by choice? That is difficult. These are some of the key performance indicators. Process indicators and clinical outcome indicators we have already covered. The business indicators could be the operation theater utilization time, the OPD wait times for a patient, the turnaround times in the operating room, the length of stay for a patient, all of that. Coming to patient experience indicators, the main issue with some of the outcome measures that we measure are it is predominantly focused on adverse events, complication, readmission, death of the patient, infection, all of that. So it doesn't give a true sense of what outcomes are from a patient's point of view. So the outcome measures what the patient thinks to what the clinician wants. There is always a gap. The patient's voices are not heard in many of the outcome measures that we measure. And the views of the clinicians to the views of the patient, when we define or talk about outcomes, there is always a gap. So the need for better measurement of health improvement on a day-to-day basis from the patient's perspective, or for it to come from the patients themselves. This is the reason we started looking at patient-related outcome measures. These are some of the patient-related outcome measures that are being done. It can either be condition-specific or generic. Condition-specific ones are Oxford knee score, Oxford hip scores. And some of the generic patient-related outcome measures are quality of life questionnaire and EQ 5D questionnaire. These are some of the limitations of patient-related outcome measures. The data is subjective. It relies on the patient's views and feelings about when you take the feedback from the patient. Some of the patients, when you do give a hospital bill with a huge copay and then ask for a feedback, it may not be very good feedback that you get. That we have seen a lot of times when we collect the feedback before the patient is offered a bill or a discharge medicine, their feedbacks can change compared to when you get it after that. Some of these patients with significant cognitive deficits, paralysis, dementia, children, unconscious patient may not be able to give this. It is a snapshot of the patient's view at one time. It's not sort of dynamic. It doesn't cover the entire spectrum of patient's journey through the hospital. And it's very unfamiliar to the clinicians and healthcare workers. This is something we are trying to adopt. And the best set of questions which is useful for us, we are still experimenting, we are learning from this. They also have tried the patient-related experience measures where these reflect the experience of the process rather than the outcome of the care. Patient might have an excellent outcome, but if he's not happy with the experience that he's had during the hospital stay, during his journey, he may not give a very good review. Now, all the historically collected quality measures were in manual form, which is very labor-intensive, time-consuming. The quality department and a lot of clinicians who do this, they spend a significant amount of time going through the chart, acquiring data, chart abstraction, formatting, reporting, and then sending it to multiple departments. So the way forward would be to go into electronic data from electronic medical records or health records and look at clinical quality measures from E or ECQM. They have the potential to automate much of this data collection and reporting process. The automatic data extraction will be significantly more efficient and accurate. There are multiple options to slice and dice the information that we get. They also the business intelligence or impact of analytics that we get from all of this, like patient wait times in the OP lab diagnostics area, the turnaround time of the critical values, the turnaround time of the lab, the OT utilization time, the infection prevalence data, antibiotic stewardship program from DDD to restricted antibiotic usage, the readmission reports, the incident reporting and audits are all automated now. We don't use a paper form to raise an incident report for medication errors and then go back and forth with paper. We can automate all of this. All the audits we told you about in international patient safety goals to hand hygiene audits can all be automated so that you have a significant information to use and train people. Some of the business KPIs like the revenue generated by the department, hospital, the volumes of inpatient to surgery, the bed occupancy rates, the average length of stay are other aspects of key performance indicator. This is one snapshot from an EMR which shows the OPD footfalls and delays for patient to be seen by a consultant for the last 18 or 19 months. This is the antibiotic stewardship from our electronic medical records. Once we automate the electronic medical records, you have multiple options to slice and dice the information. You could slice it to the period whether, like a statement of a bank, you want only credit card statement, you want only debit statement, you want for a specific time period, or you want it for last quarter or last year. You could do all of that. You can select the period, you can select the doctor, you can select the organism, whether you want gram-positive, gram-negative organism, multiple drug-resistant organism. You can select the specimen, whether it was a blood culture which was sent or whether it was urine culture. Based on that, you can get information. You can also get the department. And these are the other headings, and this is what we get. When we take the location from high dependency unit to medical ICU, surgical ICU, you know what are the culture trend where it has shown positive. So these are the information which you can get from electronic medical records. The OR utilization report, how many surgeries were done, what is the operational hours, what is the utilization hours, and this will help us to staff the operating room adequately. You will know where you're losing money or dollar in the hospital, whether you overstaff the departments or you understaff the departments. Some of the trends could be that you're not using your regular elective operating hours efficiently and that you're doing more emergency work, which means the hospital is paying more than what it should be paying. So unless you look at the economic impact of quality, only quality outcomes will not be helpful. Some of the problems with the traditional quality outcomes that we have seen or measured or monitoring is we have developed a checkbox attitude. When we look at the traditional measures like mortality rate, readmission, infection, once we checkbox all of them, it gives us an illusion of completeness. We feel everything we are doing is good. For example, when we look at readmissions, we always calculate 30-day readmission rate. If the patient gets readmitted on the 35th day, it would not show in the data. You could have a very high 40 or 50-day readmission rates. So that is why instead of using this illusion of completeness, you'll have to get out of it and you'll have to look at the data-driven all-cause approach to patient safety. And it is good if you have this data driven by electronic format so that you are not spending more time, it's more accurate. How do we know what length of stay somebody picks up and sends it to you on a paper form is accurate? Validating a lot of this manual data is quite cumbersome. That's why we are moving away from manual and getting into electronic data automation. Now, interestingly, the reason I asked how many doctors and nurses or paramedics in the room is, whenever we discuss about outcome, safety, quality, we are always looking from patient's perspective. Healthcare workers deserve to be safe too. Do all of us agree? Thank you. So US Bureau of Labor and Statistics quoted 600,000 injuries in 2007 in healthcare industry. And 10 years later, in 2017, it still stands at 500,000 injuries in a healthcare industry. In 2020, post-COVID or just around COVID time, there was a 40% increase compared to 2019 in healthcare industry injuries, and 806,000 people have had injuries occupationally or occupational hazard. And healthcare industry is the only private sector which has experienced an increase in injury because of COVID-19. This is the data where you can see we are the top. Healthcare is not safe for healthcare workers. We have to look at it seriously. So unless we look at it, it was 500, then it went to 800,000, and in 2021 it has come down. We still are the leading sector when it comes to occupational injuries at workplace. So in JCI's Handbook for Healthcare Safety, they have quoted these 5 most prevalent types of hazard. So all of us would agree from needles, sorry. Go back. Yeah. From healthcare injuries to radiation to chemicals, to all of this we have, from respiratory illness, tuberculosis, H1N1, COVID-19, all of this are occupationally, we are exposed to all of them. Now, the US Nursing Association conducted a survey in 1 year, and they found that 1/3, 33% of the people who they had surveyed had back or musculoskeletal injuries in nursing and nursing assistant department. That is significant. And assigning of extended shifts, unexpected shift changes where you disregard your family time, constant shuffling of work schedule to adjust for workers. Our schedules are based on the patient inflow. If the emergency room is filled, if the operating rooms are full, the ICUs are full, we need to staff accordingly. Physical and emotional toll are always there on every worker, which increase the risk of harm. Everybody knows about COVID-19 and the shortfall with protective personal equipment which the globe faced. And healthcare workers were at the front. They were expected to work irrespective of availability of N95 masks. A lot of us have reused N95 masks. In fact, the CDC and WHO came up with techniques how we can sterilize or reuse N95 because we were not having enough N95 masks around the world. Increasing body weight and obesity around the world, everybody is aware. So if we do have an obese patient who gets into a hospital, it is going to be more challenging for healthcare workers to manage him safely and don't have a bed sore, don't have a complication, and still send the patient home. So there's also a concept of second victim, which is not very highly publicized. Whenever we have a serious incident with the patient care, which leads to death or a complication to a patient, the healthcare worker, doctor, clinician, or nurse could feel morally responsible for having caused it or having been involved with it. Now we want to have a switch-on, switch-off attitude. If a surgeon has had a complication, he just switches off and we expect him to go back and do another surgery the same day. Same thing with the ICU staff. If ICU staff is looking after 3 or 4 patients, the moment you have a complication, when we finish all the paperwork, we expect the nurse to switch off, take a coffee and go back to her work. So she is the second victim. And the patients, these clinicians, doctors, nurses are treating could potentially be a third victim. Because we are not 100% our best after we've had a complication and after we had a complication because of what we have done. We have done it in good faith, but complications do happen. But how do we make sure that we don't have a third victim? So these are some serious questions. In a lot of studies, they were told that 50%, nearly 50% of healthcare workers, doctor, nurses, paramedic, have the second victim syndrome at least once in their lifetime. And this is a trajectory or recovery trajectory for a second victim. After you go through this, it might take months, it might take years, depending on what complication we have had. 1/3 of us thrive, means we learn from our mistakes, we start advocating patient safety factors, we train others, we train our juniors and progress in life. 1/3 or 20-30% of them drop out. They don't want to be in healthcare. Either they change the unit or they leave healthcare totally. The remaining people just survive, meaning they are not able to accept the reality. They continue to do what they're doing and they try to balance everything. So we need to have very good employee assistance program, buddy programs, peer group to support each of us. Instead of having a blaming and shaming culture, we need to learn, we need to make sure those mistakes don't repeat. To summarize, the other business case for quality indicators are the employers and third-party payers are seeking value-based purchasing. The long-term sustainability of rising healthcare cost is on the wall. Around the world, no country is able to take care of the rising healthcare cost. With elderly population, increasing quality of life, increasing age of elderly patients, healthcare cost is going up. The accelerated number of uninsured in every country is going to be a problem for the governments. The double-digit increases in healthcare premiums. Everybody has seen it. Our healthcare premiums is going 2 digits increase every year, and it is going to increase continuously. So unless we lower the cost of providing care while maximizing the quality of care and creating more direct linkages between providing reimbursement and measures of quality, it is going to be a very difficult, sustainable, viable healthcare in the long run. So the quality and safety are important factors shaping the future of hospitals and medical care. Quality and safety will define both success and failures for healthcare. So primum nocere is one of the basic dictum. Primarily, do not harm a patient. Even if we are not able to help a patient or benefit a patient, we try not to harm a patient. This is what Arthur Bloomfield told. Safety is an industry imperative. There are some patients whom we cannot help, but there are none whom we cannot harm in healthcare. So the principles for advancing patient safety apply to workforce safety as well. Workplace safety is very strongly linked with patient safety. And joy and meaning will be created when the workers feel valued, safe from harm, and are also part of the solutions that we are trying to change for patients' betterment. Healthcare outcomes are important to achieve the quadruple aim, where the fourth aim is to reduce the clinician and staff burnout. And patient-related outcome data should be seen as complementing rather than replacing the outcome indicators. Healthcare quality and safety has to be led by the leadership position to the frontline workers. And unless we create a culture that values the role quality and patient safety play in care of the patients, it is not going to improve. This is the overview of the Global Patient Safety Action Plan 2130 by WHO. Their vision was a world in which no one is harmed in healthcare and every patient receives safe, respectful care every time, everywhere. And if you see their mission and goal, all resources are avoidable towards avoidable risks and harm to patients and health workers. And the goal is to achieve the maximum possible reduction in avoidable harm to unsafe healthcare globally. This is what the Patient Safety Action Plan told. You'll have to put all the pieces together, from having a culture of safety to involving the leaders, the healthcare workers, and then approaching it. Finally, I'll leave you with this piece from National Patient Safety Foundation. Workplace safety is strongly linked to patient safety. Unless caregivers are given the protection, respect, and support they need, they are more likely to make errors, fail to follow safe practices, and not work well with teams. So when anybody has got a transatlantic flight, all of us complain about jet lag. Healthcare industry, we are asking people or staff members to do 2 nights, take 2 days off, 2 days, come back 2 nights, and it is a norm. So it's like having jet lag round the year. And how do you expect these people to do hand hygiene at 2 o'clock in the morning? Who's watching that? Your outcomes would not be good unless you take care of all of that. The protocol should be so strong that people do what they have to do even without somebody watching over them. They have to do what they are supposed to do even without a monitor any point of the day or any point of the night. This will come in, the buy-in will come in only when the healthcare workers are given the respect that is needed, and they are also made part of the solution that we are trying to have. They have to be told they are important for the healthcare outcomes. There is no insignificant position in a healthcare industry. The housekeeping staff does what she has to do so that the environmental hygiene is maintained. The nurses do what they have to do. So we have to have buy-in by every stakeholder in the hospital, from the front line to the boardroom with the leadership position. Thank you. Thanks a lot.
Thank you very much,